If I ask you to name the biggest employer of doctors in the United States, who would you guess? You would probably say a massive hospital system, right? Maybe the Mayo Clinic, Johns Hopkins, perhaps the federal government through the VA. But you'd be wrong. The largest employer of physicians in this country is actually likely sitting in your wallet right now. It is your health insurance card. Pull it out and take a look at the logo in the corner. Most of us just look at that card and see a financial safety net. Something you hand over at the pharmacy counter or at the doctor's office, just so you don't go completely bankrupt when the bill arrives. And for decades, that was the entire deal. You pay the premium, they put the risk, and you got sick, they pay the bill. But this is no longer the whole story. Today, the company behind that card may do far more than paying claims. They are generating the bills, they are processing the bills, and they're writing the rules for those bills can even cover in the first place. They are the doctors now. They are the pharmacies. They are the data processors. They have quietly built this massive infrastructure that makes them the ultimate gatekeepers of your care. Welcome to Summerlands. I'm your host, Eva. Last episode, we talked about why US healthcare is so complicated. We look at the micro story, publicly financed but privately administered. Today, we are going to dive deep private administration side. How did private insurers evolve from financial middlemen into some of the most powerful gatekeepers in the UnitedHealth Group? How did they move from paying bills to shaping the networks, data, pharmacies, and care pathways that define the patient health? How did they move from paying bills to shaping the networks, data, pharmacies, and care pathways that define the patient experience? How did they become too big to fail? To understand the trillion-dollar giants of today, we have to start with a simple but uncomfortable truth. The US health insurance was not designed as one coherent system. It was assembled through a series of crises, compromises, and workarounds. Let's start in 1929 in Dallas, Texas. As we mentioned in the last episode, at Baylor University Hospital, administrators were facing a basic financial problem. Patients couldn't afford certain hospital bills, and hospitals were struggling to get paid. So Justin Ford Kimball created a plan for local school teachers. For 50 cents a month, they would be guaranteed up to 21 days of hospital care if they ever need it. That idea became the early blueprint for Blue Cross. And what matters here is that this wasn't insurance in the modern sense. It wasn't a sophisticated risk management product. It was prepayment, a way to stabilize hospital revenue and protect patients from catastrophic bills. In other words, the roots of private insurance in the United States were modest, local, and reactive. Then came World War II. The federal government passed the Stabilization Act of 1942, imposed wage controls to prevent inflation. Employers couldn't illegally raise wages to compete for workers, so they found another way to attract talent: fringe benefits. Health insurance became the workaround. And then the IRS ruled that employee contribution to health insurance would be tax exempt. That single decision changes the trajectory of US healthcare. Because from that point on, the United States didn't build health coverage around citizenship or residency or a unified national system. It built it around work. And that matters because once health insurance became tied to employment, private insurance stopped being just a local hospital subscription. It became a core piece of the labor market. But it always left the major groups out, especially the elderly and the poor. So in 1965, the federal government stepped in and created Medicare and Medicaid. And here again, the United States made a very specific choice. It didn't replace the private employer-based model with one national system. It added public programs on top of the existing private structure. And that layering is a key. Because by the time we get to the 1970s, the basic architecture of US healthcare is already in place. Private employer insurance for much of the working population, and public programs for the populations the private market didn't want to cover. But that model had a problem. Insurance companies were still mostly passive payers. A patient went to the doctor billed for the service, and the insurer paid the claims. The logic was simple, and it was getting expensive very fast. Because in a fee-for-service system, volume drives up revenue. More visits, more tests, more procedures, more days in the hospitals. All of that mean more money flowing to providers. And as Medicare and Medicaid expanded, healthcare spending began to rise sharply, and Washington started to panic about cost. This brings us to the Nixon administration and the Health Maintenance Organization Act of 1973, the HMO Act. This was a major pivot. The government wanted a model that didn't just pay for care after the fact, but actively manage how care was delivered. Instead of paying separately for every service, Health Maintenance Organization (HMOs) were built around tighter networks, prepaid budgets, and more control over utilization. This is where the insurer role begins to change. The insurer is no longer just writing checks. Now the insurer is building the network, deciding which providers are in it, managing referrals, reviewing utilization, and increasingly influencing what kind of care is considered necessary in the first place. This is the birth of the modern gatekeeper, middleman with power, and that tension has defined US healthcare ever since. Because once insurers gain the power to manage spending, the obvious next question is, how do you stop them from simply turning that control into profit? And that question became especially important decades later under the Affordable Care Act. One of the ACA's key tools was the medical loss ratio, the MLR. The basic idea is straightforward. Insurers must spend a minimum share of premium revenue on medical care and quality improvement. If they fall below that threshold, they have to spend rebates back. If I pay like $100 a month in premiums, and the insurer spends $80 of that paying doctors and hospitals, the MLR is 80%. And before the ACA, some insurance companies in the individual market had MLRs as low as 60 or 65%. They were keeping a massive chunk of premium revenue for overhead and profit. The Affordable Care Act put a hard, strict legal cap on this. It mandates that insurers must spend at least 80% of the premium dollars on actual medical care, or 85% for large group and Medicare Advantage plans. For our listener, the exact percentages matter less than the incentive. These are publicly traded profit companies. Wall Street demands constant growth. And once you limit how much of premium revenue insurance can keep for administration and profit, you change the growth strategy. You are no longer in a business where the easiest path is simply squeezing a bigger margin out of every premium dollar. Now the game is scale. Think of it like a casino that is only allowed to keep a fixed slice of the money moving across the table. If the casino wants to make more money in absolute terms, it doesn't need to take a bigger cut off each hand. It needs more volume flowing through that building. And this is the key shift. If margins are constrained, then growth comes from controlling more lives, more claims, more infrastructure, and more of the value chain around the insurance business. And that is exactly what the biggest insurers figured out. Insurers realized they couldn't just insure people, they had to own the entire ecosystem. They had to become the infrastructure. If you want to understand what that strategy looks like in the real world, what happens when an insurer chases scale, control, and infrastructure across the healthcare system, there's no better case study than UnitedHealth Group. Because at some point, UnitedHealth stopped looking like a large insurer and started looking like a health system building inside a corporation. And the scale alone tells you that something unusual happened. In 2015, UnitedHealth Group reported about $157 billion in revenue. And by 2025, that number has risen to $447.6 billion, nearly triple in a single decade. That makes UnitedHealth one of the biggest companies in the world, not just in healthcare, but across the entire global economy. So, how does a company get so big? The first answer is scale. UnitedHealth started in the managed care era. It was founded in 1974, right on the heels of that HMO Act we just discussed. A man named Richard T. Brick founded a startup in Minnesota called Charter Income, which is later reorganized in 1977 as United Healthcare Corporation. They were built specifically to service that new managed care opportunity. Their entire purpose was purely administrative, just manage provider networks and administer benefits for employee health plans. Sitting between the patient, the employer, and the doctor, taking a fee for processing the paperwork and trying to negotiate some discounts. In the 1980s and 1990s, they expanded aggressively. They go public in 1984, and by 1998, reorganized into a holding company, UnitedHealth Group, because they are just vacuum up all these regional health plans. And like in 1995, they brought the Metro Health companies for like $1.6 billion. That was combining MetLife and Travelers' health business. And that era is defined by horizontal growth. So buying regional competitors, they acquired covered lives. If you have more members, you have more leverage to negotiate lower rates with local hospitals. So the strategy through the 90s and into the 2000s was purely about expanding their geographical footprint and their membership basis. They accelerated into the 2000s with some absolute blockbuster deals. They brought Oxford Health Plans in 2004, Pacific Care in 2005, and Surrey Health in 2008. These deals brought in millions of new members, particularly expanding their reach out west, and it really solidified their gap on the growing Medicare Advantage market too. So by the late 2000s, they are a coast-to-coast national leader. And that was the first phase of that model, horizontal growth. More covered lives, more premium dollars, more bargaining leverage with providers. But there's a limit to that strategy. At some point, you couldn't just keep buying more insurers forever. Regulators push back. Employers resist endless premium increases, and pure insurance is still relatively thin margin business. So the next phase was much bigger. UnitedHealth stopped asking how to insure more people and started asking how to own more of that happens around the insurance company, the insurance business. That is the logic behind Optum. Today, UnitedHealth is really two companies under one umbrella. The first is UnitedHealthcare, the insurance arm. That is the logo most people recognize. It takes in premiums and administers benefits across commercial employer plans, Medicare Advantage, and Medicaid managed care and other lines. And the second one is Optum, and this is where the story changes. Optum is the service and infrastructure side of the enterprise launched in the late 2010s. It spans care delivery, data and analytics, and pharmacy benefit management with three different divisions. First, Optum Health. This is actual physical care delivery. They are now one of the largest employers of physicians in the United States. They partner with roughly 90,000 doctors. They own the urgent care centers, the surgery clinics, and primary care practices. The second one is Optum Insight. This is the technology wing. They provide the software and data analytics and the claims clearinghouse that independent hospitals use to process billing, manage revenue cycles, and analyze patient populations. And third, Optum Rx, the pharmacy benefit manager. They manage the prescription drug benefits for millions of people. And the scale here, in 2025, Optum Rx fulfilled 1.66 billion prescriptions. They manage $188 billion in pharmaceutical spending, with about 80% of that being incredibly expensive specialty drugs. They operate massive mail-order pharmacies and negotiate directly with drug manufacturers. In 2025, Optum generated over $270 billion in total segment revenues on its own, and it was become the primary growth engine of the entire enterprise. And this is the key shift. When an insurance company owns more of the clinic, the pharmacies, and the data infrastructures, medical spending stops being just an external expense. It starts becoming an internal revenue. And this is the real meaning of vertical integration. Look at it from the perspective of a traditional insurance company. Your biggest expense, your biggest loss of capital, is paying out medical claims. You're taking premium dollars, but every time a patient seeks care, you have to write a check to an independent doctor, an independent pharmacy, or an independent tech vendor. Money constantly leaves your ecosystem. But if you vertically integrate, if the parent company owns the doctor, owns the pharmacies, and owns the data processor, then the money never truly leaves. They simply move from UnitedHealthcare's ledger over to Optum's ledger. And how does that look on the accounting sheet? In financial reporting, this is called elimination. The revenue that Optum makes by selling service to UnitedHealthcare is eliminated in the parent company's consolidated revenue reports, meaning they don't double count the same dollar on their final balance sheet. But operationally and strategically, it changes everything. By owning the entire value chain, the parent company captures the margin at every single step. And let's walk through a patient journey. A UnitedHealthcare member gets sick. Their insurance plan financially incentivizes them to go to an Optum urgent care clinic. The Optum doctor uses Optum Insight software to pull their medical records and process the billing code. The doctor prescribes a medication, which the patient's plan steers them to fill at an Optum Rx mail order pharmacy. So basically, UHG is capturing profit when you pay your premium, capturing profit when the doctor bills that visit, capturing profit on the software transaction fee, and profit on the dispensing of the drug. There are a lot of debate happening among antitrust regulators right now. Traditionally, regulators look for horizontal monopolies, like two massive insurance companies try to merge and eliminate competition. However, vertical integration is much harder to regulate because the company can argue, we are not a monopoly in insurance. We just happen to also own clinics and pharmacies to make things more efficient for our members. And it reshapes incentives. They have an unparalleled 360-degree view of the patient data, which they use to optimize their clinical pathways and ultimately their financial returns. Alright, we see the left pocket and the right pocket. We see the $450 billion top line, but where is all that money actually originating? Because if you stop someone on the street and ask, hey, where does UnitedHealth get this money? They probably say, from the monthly premium I pay out of my paycheck. But if you're looking at the NK, this is only a piece of the puzzle. What is fascinating here is the profound paradox it creates in the public consensus. And almost any people, they will tell you Medicare and Medicaid are government programs. The reality is, for over half of all seniors and vast majority of low-income enrollees, their day-to-day healthcare experience is not managed by government. Which doctors they are allowed to say, what prescription drugs they are allowed to take, what treatments get approved or denied. This is entirely dictated by a private corporate network operating on a fixed capitalized budget. And this is where we cycle back to our last episode thesis. Publicly financed, privately administered. According to UnitedHealth Group's 2025 10K, premium revenue sources directly from the Centers for Medicare and Medicaid Services (CMS) accounted for 44% of their consolidated revenues. It's government money. How did we even get to this point? Well, the primary vehicle for this transformation is Medicare Advantage. Traditional Medicare, the program Lyndon Johnson signed into law in the 1960s, is essentially the government acting as an insurance company. The senior goes to the doctors send the bills to the federal government, and government pays a fee. A pure fee-for-service model. The government holds the financial risk, but Medicare Advantage, which is also known as Medicare Part C, is completely different. Under Medicare Advantage, the government essentially goes to private insurance company like UnitedHealth Group and says, we don't want to process these millions of individual claims anymore. We will pay you or a fixed monthly amount per senior, and in exchange, you provide all their Medicare benefits and you take on the financial risk of managing their care. And the seniors have been choosing their private plans. And why? Because the private insurers always threw in extra perks of like traditional Medicare didn't cover, like dental health, vision, like free gym memberships. The number from the Kaiser Family Foundation illustrate a massive shift. In 2025, private Medicare Advantage plans covered 54% of all eligible Medicare beneficiaries. That is 34 million people. And by February 2026, it crossed the 35 million mark. Private corporate plans now manage the care for a clear majority of the U.S. Medicare population. And what is crucial to understand is how incredible concentrated this specific market is. It is not 50 small companies building the pie. It is very top-heavy. In 2025, UnitedHealth alone held 29% of this entire national market, and this is roughly 10 million seniors under their specific umbrella. If you add Humana, which holds 17%, or those two companies control nearly half of the entire Medicare Advantage market. And that dynamic isn't just isolated to seniors. Medicaid too. The Medicaid program, which serves low-income individuals and families, operates under a very similar model known as Medicaid managed care. As of mid-2024, about 85% of all Medicaid enrollees were receiving some form of their care through a private managed care plan, and 78%, over 66 million people, are enrolled in comprehensive risk-based managed care organizations, or MCOs. And again, it is highly concentrated among a few massive players. 5 Fortune 500 firms accounted for 47% of that comprehensive Medicaid enrollment. UnitedHealth Group holds 9% share of that 66.5 million enrollment base. Centrum holds 18%, and Elevant Health holds 11%. So the taxpayers are financing the system. We're putting up all the capital, but a highly concentrated oligopoly of private firms are actually holding the dollars and administering the program. And the mechanism that drives the profit engine for both Medicare Advantage and Medicaid managed care organizations is a financial concept called capitated payment, or capitation. In a capitated system, the government pays the private insurer a flat, fixed amount per member per month. It's paid upfront, regardlessly of whether the patient goes to the doctor 10 times a month or 0 times. Now, the amount isn't the same for everyone. To prevent insurers from cherry-picking only the healthiest seniors, the government utilizes a mechanism called risk adjustment. This means that the government looks at the patient's medical history and pays a higher monthly rate for a patient with a severe chronic illness, like diabetes and heart failure, than they do for a healthy senior who only needs a yearly checkup. Because the sicker patient is obviously going to cost the insurer more money to treat over the course of the year. Imagine if the insurer gets paid more when a patient is documented as being sicker. Then that creates a massive financial incentive for the company to just aggressively comb through medical records, hunt for every conceivable amount, and flag them just to boost the amount of money the government sends them. This raises concern in the industry as upcoding, which is currently under intensive federal scrutiny. The HHS, Office of Inspector General, the OIG, has been heavily investigating the method insurers use to aggressively capture diagnostic codes. They specifically scrutinize products like health risk assessment, HRAs, and retrospective chart reviews, driving up Medicare Advantage payments. And let's break down how this upcoding works in practice. Imagine a senior goes in for an annual wellness visit. The insurer might send an algorithmic prompt directly to the physician's electronic health record system, reminding them to conduct a health risk assessment while they're in the room. That assessment might flag, say, like 3 years ago, the patient mentioned feeling somewhat depressed, or maybe they had a slightly elevated blood sugar reading one time. The system then prompts the doctors to code for active major depressive disorder or complications of diabetes. And it gets deeper because the insurers also conduct what are called retrospective chart reviews. They hire arms of coders, often through their own data analytics arm like Optum Insight, to use natural language processing to hunt thousands and thousands of old medical charts, looking for any mention of a condition that a doctor might have noted in the text of the chart, but didn't officially submit as a billing code. And once they find it, they submit the code to the government, increasing the patient's risk score, without necessarily providing any new treatment for that condition at all, and basically mining old data for new money. In an October 2024 report, OIG estimated that in 2023 alone, $7.5 billion in risk-adjusted payments were driven by those controversy assessments and chart reviews. Now, the defense from the industry is that our accurate risk assessment is just clinically necessary. They argue that you couldn't provide comprehensive coordinated care if you don't have a complete picture of a patient's historical health. They maintain they are simply ensuring the government pays the appropriate amount for complex patients. However, the Department of Justice sees the data very differently. Multiple insurers, including UnitedHealth Group, have faced severe scrutiny, whistleblower lawsuits, and direct DOJ interventions alleging fraudulent billing practices. The allegation is that those algorithmic chart reviews cross the line from diligent record keeping to systematic profit-driven inflation of patient sicknesses. Because when an algorithm is designed to aggressively mine for lucrative diagnosis codes, the DOJ argues the primary output isn't better health. It's just higher federal revenue. It is a terrifying financial loop. On the other hand, if the insurance company manages the patient's care and the actual medical cost at the end of the year coming below that total fixed capital payment, the insurer keeps the difference as profit. If the medical costs exceed the payment, the insurer eats the loss. It creates a massive, overwhelming financial incentive for the insurance company to control utilization, and every dollar they don't want to spend on medical care is a dollar of gross margin. Therefore, they want to keep patients out of expensive hospital beds. They want to aggressively manage chronic diseases with cheaper generic drugs before they turn into expensive emergencies. They institute prior authorizations to double-check that a doctor really needs to perform that expensive MRI, and they restrict patients to tighter networks of doctors who have agreed to accept lower fees. The cost of delivering care stays well below the capitated rate the government is depositing in their account every month. While this government fireworks of capitated payments is one massive revenue stream, we can't ignore the other pillar of this business, the traditional employment market, the working age populations. In 2025, 67% of covered workers are in self-funded plans. As mentioned in our last episode, a self-funded or self-insured plan, companies decide they don't want to pay the insurance company's profit margin on those premiums. They set aside their company money into a massive bank account to pay employees' medical claims directly. They hire an insurance company to administer the plan, and the insurer shifts their role. They go from taking on risk, being a true payer, to simply being an administrator. In industry terms, they provide administered services only, or ASO. They act as a third-party administrator. So, the insurance company essentially rents out its massive network of doctors and its IT billing software to the employer. They collect administrative fees, a steady, predictable stream of revenue, without taking on any actual medical risk of the patients getting sick. This is an insulated and safe business model. And there is a specific federal legal framework that makes this self-funding ASO model attractive for large national employers and the insurance administrator who serves them a federal law called ERISA. ERISA is the Employee Retirement Income Security Act passed in 1974. The original intent was largely to protect pension plans, but it had massive implications for health benefits. The Department of Labor notes that self-insured private sector group health plans are generally not subject to state health insurance law. They are governed exclusively by federal ERISA rules. And this allows large employers to offer one single standardized benefit package to every employee nationwide. And for the insurance companies act as administrators, it allows them to scale standardized national administrative business. You don't have to custom build 50 different risk models for 50 different states. They just list out their national infrastructure to self-funded employers who are shared by federal law. And this all clicks together now. If their profit margins on premiums are capped by the Affordable Care Act, and if employers are increasingly taking on their own risk, then the real value in the insurance company isn't holding risk anymore. The real value is owning the indispensable infrastructure that employers and the government rely on to make the system function. And they realized they couldn't just process claims, they had to own the entire ecosystem. To maintain dominance as the ultimate administrators, they went on a historical buying spree, swallowing up everything around them, and which brings us to the most opaque, heavily scrutinized, and arguably most powerful part of this entire system: the hidden middlemen, the pharmacy benefit managers, the PBMs. If you look at the M&A timeline over the last decade, it reads like a corporate shopping spree of unprecedented scale. In 2015, UnitedHealth Optum buys Cattle Marine, a massive PBM, for roughly $12.8 billion. In 2017, they pivoted to clinical care and buying surgery care affiliates for $2.3 billion. In 2019, they buy Delta Medical Group for $4.3 billion. In 2022, they closed the acquisition of Change Healthcare, getting a huge chunk of the actual national data rails. They systematically brought their way up and down the value chain. But the PBM acquisition is structurally the most central to the control of healthcare cost. A PBM is a unique entity that sits directly in the middle of a very complex web between the insurance plan, the pharmaceutical drug manufacturer, and the retail pharmacy will pick up your bill. We cited the FTC interim staff report on this. The Federal Trade Commission's numbers are staggering. The big three PBMs in the United States, which are Optum Rx, CVS Caremark, and Express Scripts, now control a massive 79% of all U.S. drug prescriptions. In 2025, Optum Rx fulfilled over 1.5 billion adjusted prescriptions, managed around $190 billion in pharmaceutical spending in a single year. We will deep dive what a PBM really does in our next episode, but briefly speaking, PBM sits right in the middle, negotiate with drug manufacturers to determine which medication will be placed on the insurance plan's formulary. And in exchange for putting a manufacturer's drug on the preferred tier of that formulary, the PBM demands massive confidential rebates from the manufacturer. It's a pay-to-play system. But the PBM also negotiates with the retail pharmacies. They determine the reimbursement rate your local pharmacy actually gets for dispensing the drug. And what independent pharmacies and FTC regulators are really pointing out, it is a practice called spread pricing. The PBM might change the health plan $100 for a drug, but only reimburse local pharmacy $70 for dispensing it, and they just keep the $30 spread as profit. And if the PBM is owned by the exact same company as a health plan like Optum Rx and the UnitedHealth Group, they're essentially negotiating with themselves, while simultaneously squeezing the independent pharmacy and the drug maker, and ultimately the patient. The patient pays the price, because those massive manufacturer rebates are necessarily passed down to the consumer at the pharmacy counter. Your copay doesn't always reflect that discount. A patient's co-insurance is often calculated based on the highly inflated list price of the drug, not the discounted price the PBM negotiated behind the closed doors. And which is even worse, to maximize their own profits, PBM heavily utilize what is called steering. They design the pharmacy benefits to financially penalize the patient for using an independent pharmacy, essentially forcing the patient to use the PBM's own mail-order pharmacy or their own specialty pharmacy. It is not just the pharmacy, it is increasing reliance on utilization management across the entire spectrum of care, and specifically, prior authorization. Prior authorization is basically the process where a physician decides a patient needs a specific treatment, a test, or a medication. But before they can actually proceed, they must submit a formal request to the insurance company and wait for permission. The insurer reviews the request to determine if it is medically necessary according to their own internal guidelines. And the sources contain some deeply troubling investigative work by ProPublica regarding how this is actually handled. AI is taking over this process. ProPublica highlighted a whistleblower lawsuit containing a UnitedHealth Group algorithm called NH-Predict. The lawsuit alleged that this algorithm was systematically and aggressively denying seniors access to post-acute care. Like if the algorithm said a 85-year-old stroke victim only needs 14 days of rehab, the insurance company would just cut off funding on day 15, regardlessly of whether the patient could actually work or feed themselves yet. And the most shocking point was the alleged error rate. The lawsuit claims that the AI algorithm had a 90% error rate when those denials were appealed to a human administrative law judge, meaning when challenged, the algorithm was found to be wrongfully flagging medically necessary service as unnecessary 90% of the time. It was so bad that the federal judge eventually had to order UHG to turn over thousands of internal documents regarding exactly how this AI-driven review process was developed and implemented. And we see similar systematic hurdles in behavioral health too. Cigna also faced significantly public and legal pressure over litigations that their medical directors were automatically denying certain low-dollar claims in massive batches using software spanning mere seconds per file. But as we transition into our final piece of our analysis today, we have to look at the dark side of that scale. Scale brings vulnerability. When a single entity consolidates this much power, this much data, and this much of the national infrastructure, it doesn't just create administrative headaches for patients, it creates a critical systematic vulnerability for the entire country. Let's go back to 2022 to explain this. Optum, the service arm we've been discussing, decided to acquire a company called Change Healthcare for roughly $13 billion. The Department of Justice actually sued to block this acquisition on antitrust grounds. The DOJ argued that allowing UHG to own Change Healthcare will give them an anti-competitive view into the data of rival insurance companies. but UHG filed this suit. The judge sided with the company, and the deal went through. What exactly did Change Healthcare do? When a doctor sees a patient, they generate a claim. That claim is routed through a clearinghouse to ensure it's formatted correctly, and then it is sent to a specific insurance company, whether that is Aetna, Cigna, or UnitedHealth for payment. Change Healthcare was essentially the digital plumbing of the entire U.S. medical system. They operate the massive electronic clearinghouses that sit right between the healthcare providers and the insurance companies. Change Healthcare processes roughly 50% of all medical claims in the United States. Half of the entire country's medical billing flows through that one subsidiary owned by Optum, and in early 2024, the inevitable happened: the cyber attack. A ransomware syndicate known as Black Hat breached Change Healthcare system. They didn't just steal the data, they shut the switchboard down. It was instantaneous nationwide chaos. Doctors suddenly couldn't submit bills. Pharmacies couldn't verify insurance coverage. People were showing up at the pharmacies and being told they had to pay thousands of dollars out of pocket for insulin because the pharmacist's computer literally couldn't communicate with the insurance company. It was a nationwide financial disruption that threatened to bankrupt small providers. The crisis was so severe that UnitedHealth Group had to scramble, eventually providing over $6.5 billion in accelerated payments and zero-interest loans just to keep medical providers afloat. It culminated in the CEO of UnitedHealth Group, Andrew Willie, being called before the Senate Finance Committee to testify that a single software vulnerability could bring the medical economy to its knees. It's a huge single point of failure. The pitch of vertical integration is efficiency. But did we trade systemic resilience for that corporate efficiency? If half of the power grid goes down, the government treats it as a massive national security crisis. Here, a single subsidy goes offline and the medical economy halts. This is the ultimate antitrust reality. When market concentration reaches that level, when a single private firm's proprietary infrastructure becomes a national dependency, it ceases to become a normal company. It becomes to act as a public utility. The internet infrastructure, the water supply, the power grid, these are heavily regulated because their failure is catastrophic. Change Healthcare was essentially a public utility operating inside of a profit-driven corporate shell, without the strict regulatory oversight that usually governs vital national infrastructure. This disaster was a wake-up call. For decades, antitrust regulators looked for horizontal monopolies. They looked to see if two big insurers were merging to kill competitors. But the DOJ and FTC are now realize that the real threat is vertical. They look at the metric model. We mentioned the DOJ tried to block the Change Healthcare deal. The FTC did require UHG to divest a small number of clinics in Nevada when they bought Nevada. And more recently, the DOJ and state attorneys generally filed a lawsuit to block UHG's $3.3 billion purchase of Amedisys, one of the largest home health and hospice providers in the country, specifically citing concern over the market concentration and reduced competition in localized market. But it is important to note that this massive vertical integration strategy isn't unique to UnitedHealth. It is a playbook for the entire sector. The industry is consolidating to mimic their exact structure. CVS Health, which historically owned thousands of retail pharmacies and owns Caremark, turned around and bought Aetna, a massive national insurance company, for approximately $69 billion in 2018. And around at the same time, Cigna, another major national insurer, bought Express Scripts for $67 billion. The horizontal mergers of the 90s has been entirely replaced by massive vertical integration. The result is an oligopoly, a hand of mega corporations that control both the financing of the care and the actual physical delivery of care. So, what does this leave us? We started back in the 1920s with simple local plans fueled by wartime tax loopholes. We have traced how UnitedHealth Group and its peers evolved from modest financial safety net entities, then processed paperwork and pay bills into the absolute architects of U.S. healthcare. Through their dominance in Medicare Advantage, Medicaid managed care, and their administration of self-funded employee plans, they are predominantly operating on public tax dollars. And through vertical integration, via massive service arms like Optum, they have captured the entire supply chain. When you stand back and look at this entire landscape from the summit, a very specific and very old pattern emerges. It is a pattern of the company town. Today, we are seeing the healthcare company town. If the company you work for hires an insurer that owns the primary care doctors who examines you, the software what processes your data, the PBMs that decides what drugs you can take, and the pharmacies that dispense the drug, every single one of us is in a closed loop. For the corporation, it is a dream of seamless efficiency. However, efficiency is not resilience. For the patient, for the science, it is a lack of leverage. If the algorithm says no in a company town, there's nowhere else to go. It is vital to remember why this complex corporate history matters to you directly. Every deduction you see on your paycheck for a premium, every confusing form you have to fill out at the pharmacy counter, every time you or a loved one are told a procedure is denied pending prior authorization, none of this is an accident. It is the intentional output of a carefully designed, vertically integrated corporate architecture built to maximize margin at every step of your health journey. Whether this system is working for you or working on you is the defining question of modern healthcare. Thanks for joining me on this episode. If you found this interesting, please subscribe and share it. Stay curious and never stop asking questions about the invisible system that govern our lives. See you next time.